Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. This education episode is very special as it is kicking off our surgery series.
The very first.
Yes, so hopefully in this series what we'll do is hopefully bring on some surgeons or other physicians and talk about, the rehab process of certain surgeries.
So who do we have on today, Randy?
Yes, for our first guest in the series, we have Dr. Michael Shepard. Dr. Shepard is a board-certified orthopedic surgeon who is subspecialty trained in sports medicine. Dr. Shepard's clinical expertise includes elbow and shoulder injuries of the overhead athlete, elbow arthroscopy, and complex knee reconstruction. Dr. Shepard has been in practice in Orange County for 20 years at the Hoag Orthopedic Institute and the Orthopedic Specialty Institute, where he cares for athletes at all levels, including the professional leagues, NCAA, U.S. Olympic teams, and youth sports.
Yeah, Dr. Shepard's been really helpful for athletic trainers in the community. I know I had the pleasure of watching a surgery under him.
Yes, as have I. Not a knee one. I was lucky enough to get an elbow one with him, but yeah, he's always willing to learn. That's been awesome.
And speaking of learning, stay tuned. We're going to talk about his website at the end of this episode where you can get more information that he has. He has a ton of stuff on patient information, some rehab plans, stuff like that.
All right. Let's hear it from Dr. Shepard. So one of the first things that, patients have to consider and then, ask the athletic trainer, the athletic trainer trying to help educate the patient is what kind of graft type. So what are some things that patients or AT should consider when they're deciding on the graft type?
Yeah, I think that, whenever I prep someone for a surgery or talk to them about ACL injury, I kind of have the normal spiel that I go through with everybody, right? And I really do that with everyone, whether they're 10 years old or we had an ACL as young as 8 years old this year. And I had an ACL that was 67 years old this year. And they kind of get the same talk no matter what. Obviously, we're more focused on 15 to 25-year-old athletes, right? And that's the majority of my practice. But we do have some outliers all over the place. So I usually talk about all the different graft types. So I usually start off by talking about patellar tendon. Patellar tendon is what I had in 1991 on my right knee. It's what I had in 1994 on my other knee. And I've been pretty much A-okay. What I usually tell people about patellar tendons is, hey, it's from your own knee. It's really strong. And the chance of it re-tearing in the broad databases like from Norway, Australia, or even the biggest database in the United States is the Kaiser Permanente database, a couple 100,000 ACLs. And patellar tendon in that database, 2 to 4% failure rate, right? So that tells you that's a pretty successful surgery. And so what I usually tell people, there's not many surgeries we do in orthopedics that are more successful than that. So I tell people, hey, patellar tendon, tried and true, 15 to 25-year-olds, especially athletes, that's usually what we're going to favor. The vast majority of professional athletes are going to do a patellar tendon, even though you'll see lots of people that maybe are giving lectures about hamstrings or quads or cadavers. When they have a real pro athlete, they end up doing a patellar tendon, right? And so, so I think so I start with that. Okay. I usually then say, gosh, you can get a successful surgery with a cadaver graft, or an allograft, whether that be soft tissue allograft, meaning all like hamstrings, or partial bone like a tibialis anterior or an Achilles, meaning you have one piece of bone and then a long tendon, as opposed to hamstring that has, obviously it's all tendon. Or you can even have a patellar tendon allograft. So any of those allografts in the databases around the world, failure rate 12 to 20%. And believe it or not, the cadaver grafts fail more in the younger people. And that's usually something of a misunderstanding, or some people think that seems weird. But the reality is, if you take a 15-year-old and you put a cadaver graft in them, they feel so good so quick. They're the kid that's out there trying to play again at 8 weeks. And we just know that doesn't work biologically, right? We know that it takes a long time for that graft to heal and to undergo a ligamentization process. And even though I've had patients maybe try to go back to play at 4 months, and we talk about some people going back to play at 6 months, most people get more comfortable about going back to play at 9 to 12 months. But allografts in the younger people do worse. Now, believe it or not, the databases show that if 50, people my age, over 50, you put an allograft in them, they actually do pretty good because lower demand. Instead of playing soccer 7 days a week, that person might play soccer twice a month, right? And instead of skiing 100 days a year, that person's only skiing 5 to 10 days a year, right? So allograft can be good, but I usually tell patients, hey, allograft is something I think about more in people over the age of 35 or someone over the age of 40. Lower demand, people that can be smart about the rehab, meaning they're not going to push and try to go, hella skiing in 3 months post-op, stuff like that. The nice thing about cadaver grafts, obviously, you don't have to lose any body parts for that. Also, maybe a little bit of an easier rehab. So if you have that person who's 42-year-old single mom or 42-year-old single dad that maybe is going to have a hard time getting to physical therapy, their therapy will probably be a little bit easier because they had a cadaver graft. So I think there's a good landing spot for cadaver graft for those people. Hamstrings, all soft tissue. We don't see many pro athletes do hamstrings. Hamstrings, you can do well with a hamstring. In the big databases, though, they usually fall, kind of behind patellar tendon grafts, and sometimes fall back as all the way back as in performance or retear rates as much as a cadaver graft. For me, I think the sweet spot for hamstrings is maybe that 10 to 14-year-old boy or girl who still has a lot of growth potential left, and you have to do a graft that maybe doesn't violate the growth plates. So you need a soft graft with no bone plugs. So that way you can avoid the growth plates, 100% avoid them. And you can't really do that with a bone plug. And so there's a good role for hamstrings in that scenario. I don't see a lot of high-level athletes doing hamstrings. And it can be a little bit regional dependent. The example I usually use is like for a long time, Penn State volleyball, which is, obviously top volleyball in the country for women's. They were big fans of hamstrings, right? And so you can see people be successful with it. So it's not an absolute, nothing's black or white. I always tell the patients that, ACL surgery is kind of like having you need to have all the tricks in your bag to do it successfully, because if you only have one option, you're probably going to miss out on providing the right option for people, right? Fourth option that I talk about is quad grafts. So quadriceps grafts above the patella. You're certainly seeing more and more of that. You can take it with a piece of bone from the patella and then a big long quad tendon off of it. Or you could just do 100% soft tissue. It's a little bit beefier or a lot beefier than a hamstring graft. I think what you'll see is, I think you'll see a lot of people that maybe used to be hamstring graft people kind of transition to more quad tendon. I do think you get a very good quad graft. Personally, I don't do a lot of quad primaries. Some of my partners do. I will use the quad, though, in people for revision scenarios because it's good tendon tissue. Also, if let's say they have a reason they can't use patellar tendon, old Osgood Slaughter ossicle or something like that, or maybe they've been harvested before. I had an athlete that was a judo athlete, world champion, and she'd had a bunch of failed allografts. She had a problem with her patellar tendon. We did a quad tendon. She did really well and went back to world championships and stuff like that. So I think there's role for all four of those grafts. Like I said, for me, in your typical patient, 15 to 24, 5-year-old high-level athlete, I'm going to lean towards patellar tendon, but I'll occasionally have some parents do some research, or the kids do some research, and they'll say they want something or the other. And I'm very open to that. But I'll tell them that even though the quad tendon is going to be more people are going to start turning to that instead of hamstrings, it's going to be hard for any of those grafts to prove that they're better than 2 to 4%, which is the patellar tendon, and has been shown all around the world. And so when you get that reproducibility in multiple databases, I think that's a strong indication that it's maybe your overall winner in that 15 to 25 group.
Interesting. We're only a few minutes in, and I learned something new. I didn't know about a quad tendon graft.
Yeah, and even when I was in training 20 years ago in Alabama, we did some quad tendons, but mainly for revisions, right? And there's been some people around the country now to really champion quad grafts. I think very similar to like Tommy John reconstruction, or the mini Tommy John in the elbow now. Until someone really, really, really big time gets a quad tendon and then performs well, you won't see that huge pushover, right? So there's a little bit of mystery about the whole Kawhi Leonard thing. And did he have a partial ACL? What was his graft? Now that he's finally back, you can at least see his scar on his knee when he's on the bench. Certainly it appears that he had a patellar tendon reconstruction. So, if someone like Kawhi Leonard, though, went out and had a quad graft and did really well, then you might say, oh my gosh, quad tendon's really, really making a splash, and you're going to see more and more people do it. But it takes that one big landmark person.
Oh, yeah.
And so then that kind of turns the whole community on the ear. And for me, it's one of those things where, gosh, I've pretty much been patellar tendon my whole career, and luckily for me, that's been really kind of borne out by the research still as, I think the overall winner. So as opposed to maybe someone who 15 years ago was doing double bundle ACLs, you probably don't hear anything about double bundle ACLs anymore. Part of the problem with the double bundle ACL, which was really hip in 2005 and 2010-ish era, you had to be cadaver, right? So if you're going to do all cadavers, you're going to have failures, right? And so, you used to have, double bundle people in 2005, 2010. Then those people became maybe hamstring people in the 2010s. And now those people are becoming quad people in 2020s. So luckily for me, I feel like I've picked a winner and stuck with it, kind of dance with the one that brung you type of thing.
Awesome.
Actually, that brings up a good point. When you have someone who re-tears their ACL, do you typically go for a different graft?
So it's a very good question. So what I would say is that, one, re-tear is like the most devastating thing, right? So we go through all this work. Patients worked, the surgeon's time is only like an hour, right? So the surgery is like an hour. It is some patient visits and some cheerleading and some rah-rah and stuff like that. But the patient's done hundreds and hundreds of hours with their PT, with their ATC, maybe with some, transition from PT to play type of, athletic trainer or professional trainer. So they put in tons of hours. So to re-tear is devastation, right? The one thing that we talk about, or the thing that I can tell you for sure, if allograft is bad as a primary graft, it's even worse in a revision scenario. So even though the temptation is, gosh, I'll do a cadaver graft, it's really the worst possible time in my mind and in a lot of the research mind to go ahead and do a cadaver. So let's say the patient had, if the patient had a hamstring first, that's easy for me because I'm going to do a patellar tendon second. So
Right.
I'm going to say, sorry, you lost your hamstrings. Also, because hamstrings tend to have smaller holes and smaller tunnels, it's a little bit easier to come in with a bigger tunnel and perhaps revise that person. You could go, obviously, if they had a patellar tendon or a cadaver graft, you have to worry about bigger tunnels. Certainly, sometimes we see people that have had failed cadaver grafts, and the holes in the tibia and the femur are so big that person can't go on to have a one-stage procedure, and you might have to do a bone grafting. So you take out all that cadaver crap that's never healed. Can I say that on a podcast? Is that okay?
Yes, you
Yes,
can.
you can.
We can make it explicit if we have to.
So you got to take all that cadaver material. And what you'll find is when you take all that cadaver material out, none of it really incorporated, or a lot of times it never incorporated at all into the bone. So you take all that out, you take the fixation out, whether that be screws or posts or whatever. And now instead of a 10 millimeter hole like we normally work with, now we maybe have a 30 millimeter hole. And if I have a 30 millimeter hole, I can't put a graft in there because I can't harvest a 30 millimeter piece of their patellar tendon. That's their whole patellar tendon, right? So in that case, you'd have to bone graft, wait 3 to 6 months, then come back and do your graft of choice. Certainly patellar tendon's a good graft for revisions. If they've already had a patellar tendon, you could think about going contralateral knee patellar tendon, which is always kind of a leap of faith for patients because they're like, ooh, I failed a patellar tendon before. Do I really want to mess with my good knee? On the same side, or the ipsilateral side, you could go quad tendon. You could go contralateral quad tendon. The one that can be hard to do is it's hard to do a revision with a hamstring because, again, even if you quadruple that hamstring, it ends up maybe only being a 7 or an 8 millimeter. And if you have a 10 millimeter, I know it's hard. If you have a 10 millimeter hole and a 7 or 8 millimeter graft, it's too small, right?
Mhm.
And so all those things got to play as to in a revision scenario. So yes, graft choice makes a big deal. 2, how big are the tunnels? 3, where are the tunnels located, right? So if we think about the number one reason that ACLs fail, it's usually tunnel placement. So where they drilled, and that's why I make a big deal when I take my pictures on my patients to show them, hey, this is where your ACL used to be attached on the tibia. We drilled right into that area. Hey, this is right where it used to be attached on the femur. I drilled right into that area. I think especially with like pro athletes, that's an important thing because a lot of times with the pro athletes, you get second guessed by people. And, that way, if someone second guesses you, then you just go right back to the pictures. And so say, I know Dr. So-and-so is looking at your MRI, but remember I showed you this picture. That's right where your old ACL used to be. That's where we drilled. So you kind of try to point that out to the patient and educate them that way. But yeah, so revisions can be difficult in terms of quad or graft choices. Kind of depends on what they had before. Also, all the different problems you're trying to fix or correct.
Awesome.
Yeah, that makes a lot of sense.
Yeah, for sure.
So kind of shifting more towards pre-op. When an athletic trainer is focusing on a patient who is going through pre-op or before surgery, what are the most important aspects that the athletic trainer should be focusing on?
Yeah, I mean, for me, the thing that I tell all the patients is, gosh, the idea of the pre-op or the prehab, so the pre-rehab, is that if you go into surgery with a stiff knee, you're going to come out of surgery with a stiff knee because you already had an insult with the injury. The surgery is a second insult. And so, especially like when I was a kid in the 70s and 80s, right? Lots of people would tear their ACL maybe in Big Bear or Tahoe. They'd get their ACL surgery the next day. And we kind of figured out that isn't the greatest thing in the world for people. And even I think the trend now is even less in like the major leagues, like, NFL and things like that. You rarely hear someone tearing their ACL on Sunday and having surgery the next day. If patients ask me about that, I usually tell them, hey, that timing is because that doctor's worried that so-and-so is going to go somewhere else. So they decide to do it immediately. I think you take a risk in that scenario because you add inflammation on top of inflammation, and then maybe that patient's stiff. So for the ATC, physical therapy or range of motion is super, super, super safe, right? So active and passive range of motion, super safe. I know a lot of times the ATCs are really worried about injuring the people or, contributing to problems. But we're not talking about any sort of, dynamic activities. We're talking about just pure range of motion. And then After range of motion, I would think about inflammation control. I'd think about quad activation, especially VMO activation. And, so for that, isometrics, quad sets, leg lifts. The nice thing too is that if you can teach them how to do their range of motion, do their quad sets, how to really fire their quad effectively, it's just going to make their rehab that much easier post-op. Occasionally you get that patient who post-op didn't do any prehab, and then they're like, what's a quad contraction, right? And then it's harder to learn that skill when you're in a ton of pain, because all that feedback of pain coming from the inflamed joint is telling their quad not to activate. So I think range of motion, quad activation, isometrics, leg lifts, it gives them a good chance to try to get things going. I'm not talking about any dynamic activities. I usually put them in a hinge knee brace, just a simple hinge, kind of like an MCL brace, just to give them confidence moving around. Once they have enough range of motion, certainly riding a bike's okay. I tell people that, gosh, I see lots of ACLs the day that the injury happens. It is rare that we operate inside of 2 weeks, right? So almost all of our ACLs are in that 2 to 3 week range. Even our kids that are go, got to get back for next season. I just tell them, gosh, if you don't have the range of motion, you're better off pushing it back another week and getting that back. A little bit along that vein, I don't have any problems with kids taking anti-inflammatories, right? So ibuprofen, Advil, Aleve, naproxen, whatever you want is fine by me. Some physicians kind of freak out and they, really don't want people on something as a potential blood thinner going into the surgery. But in young, healthy kids, I'm not real worried about them being on Advil or, naproxen right up to the day of surgery. I really don't worry about it at all. Okay. So for me, I think we don't have to get fancy in the prehab phase. It's mainly so that the kid can feel comfortable with firing their quad, moving, so they're not going into that surgery with a super stiff knee.
Does the focus change depending on the graft type? So, like if you're going with the hamstring, are you focused more on hamstring activation, or are you still just trying to get that quad activation and just everything in general?
Yeah, I think it's a good question. I think, post-op, they're definitely going to be, firing their quad, right? Post-op, if they harvest a hamstring, there's no hamstring to fire. So, because they're losing a 14 centimeter length of the tendon. So, I don't think it changes a ton, but I do think, to your point, is it's nice when the kids in prehab, whether that be in the training room or at a physical therapy center, for that kid to look around and see, oh, that's what an ACL looks like that's 2 weeks post-op. They're in a lot of pain. Or that's what an allograft looks like, or that's what a hamstring looks like. And a lot of times you don't have those different types of grafts walking around the training room, right? Because, you probably have a team doc that has a certain preference, or everyone's going to be patellar tendons or everyone's going to be hamstrings. But I do think going through the prehab time is a good chance for that athlete to look around and kind of get a feel for what the different stages of their rehab is going to be. And that definitely just helps them be more emotionally mature and ready for the surgery.
So you mentioned a hinged knee brace. When would you change from a straight leg to a hinged?
Yeah. So what I use I use the straight leg brace, mainly when they have no quad control. So
Okay.
from my standpoint, and that might be acute phase, right? So after you have those kids that, tear their ACL and, everything goes crazy. And, that kid comes into, the clinic the next morning or comes in the training room the next morning and they can't fire their quad at all. And you're like, oh my gosh, it's only been like 18 hours and this kid's quad's already shrunk a ton. So in that person, I just don't want that kid falling down over and over and over again, right? Because then they've called 911 like 3 times from your campus, and it's not cool. So I'll use a knee immobilizer to help protect that kid. Let him weight bear as tolerated. I will say that might be a side little thing too. There are some docs out there that will say, "Gosh, I'm worried your meniscus might be torn. I'm going to keep you non-weight bearing going into surgery." For the stuff that we just talked about, I don't think that we're injuring a meniscus tear more by working on simple range of motion. So I let the kids weight bear. It's good for, fluid control. It pushes that fluid out of their cankle, right? And gets that fluid out of their ankle and helps them rehab quicker. So I'm okay with weight bearing, but same sort of thing pre-op as post-op. Post-op, everyone's locked in extension except for when they're in rehab. And that's because their quad's weak, and I don't want them falling down, splitting their wound open, or just, all those things that can be a problem more so even in the post-op phase. So post-op phase, they'll probably be in a knee immobilizer or a locked out brace straight for maybe a week, maybe 2 weeks.
Okay, nice. So you mentioned, as a surgeon, right? You get such a small time with them, and then you get your follow-ups. What are some of those things that you're looking for each time a patient comes in for their follow-up, whether it's, a few weeks after the surgery or a few months?
Yeah, I think and we kind of have we have all the different visits, right? So it's kind of a journey that you go on, and not everyone's journey is the same, right? And so it's not always cookie cutter, right? It's not like I just click and paste visit 1, visit 2 note, visit 3 note, right? Everyone's journey is a little bit different. But, in the first phase, week 1 and week 2 visit, we're talking skin healing, right? I want skin healing. I want to start doing patellar mobilization. I want to start doing quad sets. I want to make sure that kid's plugged into, either the training room or a physical therapist, right? And that again is a benefit of prehab, because if the kid doesn't like the place in prehab, you find them another place before they have surgery. The time to be looking around or, therapist shopping is not, I'm 14 days post-op and I haven't gone to a single PT visit because I really didn't like the first place I went because everyone was old, or everyone there was jerk football players like Mike Shepard was in the 90s, right? Or in the 80s. So it's great on the prehab side to get used to and find a place that you like. So week 1, week 2, wound care, patellar mobilization, range of motion. Week 4, week 6, I really want them full range of motion by week 6. So that means they got to have full extension, which is the most important thing in terms of being able to run fast. And I want to see their flexion nearly full by week 6. If that looks all decent at week 6, then I'm going to tell them I'm not going to see you for 2 months. Okay. And I usually tell people that sort of week 6 to, week 14 or 14, 16, something like that, is really the boring type in the time of the therapy, right? Because they're not really making huge gains anymore. So it's kind of the doldrums. On the flip side, that week 6 visit, I usually call the come to Jesus visit, because I tell the kids, look, you're feeling better. You're starting to be able to get on a bike and elliptical and stuff like that. But now is not the time to go run wind sprints or play soccer or jump off the roof of Del Taco, all of which are things that my patients have done in that week 6 to week 14 range, right? Or fall out of an El Camino going 45 miles an hour down Irvine Boulevard. All those kids did not retear, but it scares the heck out of me when those things happen. When I get the phone call and I'm like, what do you mean you jumped off the roof of Del Taco on Tustin Avenue? Why would you do that? Well, the cops were coming, Dr. Shep. And so, those are all the hold your breath moments until you see the kid the next time. Now, at the 3.5-month visit, after the come to Jesus talk, if they are looking good and they can do a good 2-legged squat, and maybe they can even do a 1-legged squat, then I'd say, okay, maybe you can start doing some jogging, okay, under the guise of therapy, right? On a train, with your ATC watching you on a treadmill or something simple. And then if that looks better, then we're going to progress onto a field. Every visit after that's kind of monthly, right? At month 6, some of the kids are looking really good, and maybe they're ready to start doing some drills at practice again. Maybe because of timing, we know, hey, we know we're redshirting this year. There's no reason to push. We'll keep you going slow. And so then from that point on, then it's really talking about transition to play. Are we going to transition back to play months 7, 8, 9, months 9, 10, 11, 12? those types of things. So I think every post-op visit's kind of a journey, sometimes you have to, not everyone follows the same path. And so sometimes you got to cheerlead. Sometimes you got to be more of a bad cop, and let someone else be the good cop. Sometimes people are just, kind of Goldilocks. They're just right. They're not trying to do too much. They're not doing too little. They're right in between. They're just right. But we don't get a ton of Goldilockses, right? Everyone's just like dealing with athletes. A lot of them either think more is better, right? So you tell them to do 3 sets of 30, leg lifts. And then you get that kid that does, I did 3,000 leg lifts yesterday, and now my knee really hurts and my patellar tendon's all flamed up. Or like a kid a few years ago, I told him it was okay for him to get on the elliptical, and they called me and sent a picture of his knee and it was all swollen. And I'm like, you got that from doing the elliptical? And he's like, I did it for 14 hours.
Oh my gosh.
They watched the whole Lord of the Rings trilogy. And so 14 hours he was on the elliptical. And I'm like, hey, that's too much for a 6-week post-op meeting, right? So there, patients do funny things when we're not around. And so a big part of the therapy, on the ATC side is trying to figure out that Goldilocks kid. Who do I need to dial back? Who do I need to encourage and push, right?
Yeah, Goldilocks makes our job too easy.
Yeah, it makes it boring.
Oh, there's not many Goldilocks in Southern California, I'll tell you that. Most of them are trying to do too much, right?
So along the lines of the too much part, what are some complications that AT should kind of be aware of? Like, I think this year I had someone with a cyclops lesion, and that was the first time I've heard of that.
Yeah, so I think the typical complications, I think biggest complications, lack of compliance, right? So when you have that first post-op visit, or the first time they come to the training room and they're not wearing their brace, big red flag, right? Hey, you don't have a good enough quad. You're going to ruin your knee by doing all these things. Second big risk really would be more stiffness than anything else, right? Because you have that kid maybe that is just struggling with range of motion, and that's why we spend so much time doing visits in those first 6 weeks. I see them at 1 week, 2 weeks, 4 weeks, 6 weeks, right? So stiffness is probably the biggest risk. Blood clots, incredibly rare, right? But they gain a lot of media attention. There was another kid, I know about 4 years ago, there was a player at University of Texas Longhorns who died of a pulmonary embolus after ACL. Incredibly rare, right? But that's a significant complication. When those things do happen, usually it does make headlines, right? Very rare in that young, healthy population. But that's also why we get people moving right away, putting weight on it right away, using leg squeezers right away, those types of things. Infection, incredibly rare, right? It happens, but usually that infection person happens maybe in that kid that's not been compliant, shows up at the training room, their wound's all uncovered, and you're like, whoa, what's going on? I had a patient this year, not an ACL, but a shoulder surgery. And they called me and they're like, I got everything. And I was in the shower today. I'm like, you just had surgery like an hour ago. And they're like, we took all the dressing off and got in the shower. I'm like, the instructions say keep it on for 24 to 36 hours. So infection is rare if people follow guidelines, right? But it can happen. And so, but something you want to keep an eye on. Cyclops lesions, a little something different because the ACL kind of lives in a notch, right? So there's a notch of the femur and the ACL attaches on the lateral wall of that, right? But you got to remember on the medial wall is also the PCL, right? So you got those two ligaments that are crossing, living in the notch. And the PCL has a pretty stout layer of synovium around it. And when we put an ACL graft in there, there's a healing process that goes on. And that's pretty well documented. We call that a ligamentization process. So some tissue gets removed, some new tissue gets laid down. There's neovascularization, where you have blood vessels growing in from the either end of the bone. That neovascularization or stimulation to make healing can sometimes go awry and be over healing, right? And that leads to something like you talked about, the cyclops lesion, right? I will tell you, a lot of times the cyclops lesion's actually coming off the PCL, but think of it as like synovial cells that got so stimulated or turned on by the injury that they make this big ball of scar tissue. And that scar tissue might be small, but it might be that kid that kind of always has a hard time with extension, but we get it back in therapy. But then maybe next time, the first time they go out run, their knee gets kind of swollen. They have a hard time with extension. They get it back. But maybe they had great motion from, 0 to 4 months. And then it just seemed like as they got farther and farther out, their motion got worse in terminal extension. And that could be that cyclops, every time they go out and run and they generate some more bleeding, it gets a little bit bigger each time. So each time they run or do a lot of activity, they get bleeding, the cyclops get bigger and bigger to the point where now they're having a hard time contracting their quad. They're not able to function normally. Get an MRI, it shows a cyclops lesion. Typically, early on in my practice, 20 years ago, I was always like, oh, we're going to try really hard to get them better. I'm going to steroid shot them. We're going to make sure we stretch them really hard after every time they run. But now I'm more apt to just say, look, you got a cyclops. It's abundant healing. Let's take the cyclops out and you'll feel a ton better. And typically that's what happens.
Oh, nice.
Trying to think other complications. Failure is like what we already talked about. Graft failure is obviously the most devastating complication, but usually pretty rare. It can happen. We think about failure in a couple different categories. Early failure would suggest loss of fixation strength, right? Either the screw or the pin or whatever device they used to fixate the ACL had early failure. Luckily, again, with a patellar tendon, we don't see that very often because since I'm putting a screw into the bone and I hear the bone go squeak, 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 I know that screw's really tight and the chance of it breaking apart is really low early on. But some of the fancy flip buttons and things like that, they can fail early on. So early failure in the first 6 months, unusual. When we get a failure that maybe is at a year out or 2 years out or 3 years out, I usually kind of shrug my shoulders and say, gosh, you tore the ACL that God gave you. Certainly you can tear the ACL that we gave you with a surgery. And so I think I just call that a retear. We also think of failures sometimes as being biologic failures, where maybe it's a cadaver graft and they kind of feel good and then they just kind of feel softer on exam more and more, like as they get farther out. And you do the MRI and you look at the MRI and you're like, man, the graft just looks kind of dead. And again, I think that's more common in allografts just because you're putting dead tissue in there and sometimes it doesn't incorporate strongly. But that's pretty much most of the complications. Injury to the artery at intra-op, incredibly rare. I've seen 1 or 2 in my careers, not involving me, but involving other surgeons. But those things are really, really, really rare. Obviously there's meniscus tears that happen and cartilage injuries that are there at the time of surgery, but pretty unusual that that's a result of a complication.
So going into that surgery, what do you wish more ATs would ask regarding the surgery or maybe the process in general?
Yeah, it's a good question. There is such variation, right? And so I think it's hard to predict, but I think when you see that patient pre-op that struggles with their range of motion pre-op, that's the person the AT should be like, we need to see, Mary or Mike the next day after surgery because they really struggled getting their range of motion back after injury. That's someone that really needs to get clued in right away. As opposed to someone who maybe got their range of motion pretty easily, kind of has things on top. Those are people that maybe don't have to be seen right away or be clued in, or maybe that person that really struggled, maybe they need to be double teamed between seeing their ATC Monday, Wednesday, Friday, seeing the physical therapist Tuesday, Thursday, just to kind of give them extra TLC to make sure they maintain their motion and get going with their motion. I think the other question, the biggest things, weight bearing status, right? Did they have a chondral defect? Do they need to be non-weight bearing, which is a possibility? Did they have a meniscus repair? Not a meniscectomy or a partial meniscectomy, meniscus repair. If there's a meniscus repair, sometimes we make them touchdown weight bearing if it's a heroic type repair. Most repairs I let people weight bear an extension. It's just that we'll keep them weight bear an extension for 4 weeks. So those are the biggest questions I think the ATs should be thinking about. Is there an alteration to our normal plan, or is this just a straight up ACL? I can weight bear them and get them going. So those are the big things to think about, I think.
So kind of flipping around and going to the end of rehab, what do you look for when making the return to play decision?
Yeah, and return to play is, it can be a little bit of a challenge, right? You have some, and I guess that's my usual. I'm using all my good analogies on the podcast, and so I don't want people to steal them. But what I usually tell people is that there's different types of patients, right? And my general thing would be a lot of kids are either rocks or flowers. Okay. And I say right off the bat, God made rocks and God made flowers. So they're both great. Right. But they're different, and you don't rehab a flower like a rock, and you don't rehab a rock like a flower. And I can tell you, I have 4 kids. I look inside the house to make sure no one's watching, but I have 2 that are rocks, right? And when the rocks tell me that they hurt or have pain, I take them seriously, because often they've been playing on a fracture or something like that. My 2 flowers, I get a new pain or injury almost every time they go out. So go out to play, that is, right? And so I'm less concerned about my flowers problems. So, and I think return to play is a big difference for that too, because you might have a rock that's dying to play and they're not ready, right? Mm-hmm. And you might have a flower that you're like, man, you're testing great, and you're trying to push that flower out there to play more, right? And so I think that's where the functional testing really helps. Obviously in Southern California, we have a lot of really great physical therapists, and like we have the Powers Lab at USC, and there's lots of people that do sort of video-based assessments of running, cutting, deceleration. And there's lots of places for people to pay $800 to $2,000 to get cleared for, to return to play. Not really in most people's budget, right? And probably not really necessary. So I'm a big fan of functional testing. I'm a big fan of the triple hop test. So if on that single leg triple hop test, they can score 90%, I tell that kid they're just as likely to tear their left ACL as their right ACL. And that's about as well as we can do from a surgical standpoint. So I do think the functional testing, single hop test, broad jump test, triple hop test, those are all things that can really kind of bolster that flower and make the flower feel better. And or if they score poorly, you just tell the rock, I'm like, dude, your triple hop test is 14 feet on the left and it's like 11 on the right. You're going to hurt yourself if you go back to play. You're not ready, even though you think you're ready, and or you think the laws of nature don't apply to you, right? Because everyone thinks that they are going to be like Adrian Peterson and come back in 6 months, right? Not many people are like, I'm going to be just like Kawhi Leonard and come back in 20 months or whatever it was that he came back in, right? And so I think the functional testing is great. It's cheap. You can do it at any place. And so I think I would clue in on all that stuff, as opposed to really trying to think about, oh, maybe we should get the department to spend thousands of dollars on some of these fancy lab tests. I don't think are probably necessary.
Okay, interesting. What about the role that a brace would play in that return to play? I've seen some kids who go on without it, and then some that like need it. What role does that play?
Yeah, and I think it really dovetails, right? So sometimes you have that kid that's dying to play, and they feel like being in a brace is going to protect them, right? So I always tell kids, look, there's no proof a brace works. Even though it's like a $2 billion industry in the United States, there's really zero proof that it's going to prevent an ACL tear. And that's because you have this huge quad muscle on your leg. The brace sits on top of the quad muscle. That means the brace is like 8 to 10 centimeters or inches, depending on how big the kid is, away from the femur bone. There's no way the femur bone's being controlled by that brace. And we know that for the ACL to tear, it only takes like 2 to 3 millimeters of laxity and it pops it. So a brace that is around 10 centimeters of soft tissue isn't going to protect that, right? That being said, some kids are scared and wearing a brace makes them feel better. That being said, some ATCs are scared and wearing a brace makes them feel better, right? And I've certainly worked at schools that are, have both scenarios where maybe an ATC wants everyone to wear a brace for 1 year. Personally, I'm not a big brace guy afterwards. The reason I don't like braces, one, there's no proof it works. Two, very often I feel like people that are in those big bulky braces don't get full extension. And so it changes their kind of workout and running habits. And if you don't get full extension, you don't fire your quad. And if you don't fire your quad, that's bad for your ACL health, right? So, and then the third thing would be that it does alter some of the quad hamstring balance. And so you see that kid who may be in the first half of a soccer game or a football game looks really quite good, but after having that brace kind of tourniquet on their thigh for 2 hours, now they're limping in the second half, and you're like, there's no reason for that kid to limp. He's limping because he has a brace on, really.
Yeah. So Sandra's a big action person.
Okay.
Yes, I am.
So this is her thing right here. Let's do some action.
So for our action item, what advice would you give to someone rehabbing an ACL for the first time? And I think specifically more in the later stages as well, because I feel like a lot of us have a good grip on range of motion, early stuff, but I feel like especially for the first time someone rehabbing an ACL, you kind of get into those muddy waters kind of later on.
Yeah, it's a good question. Because certainly I've had athletes on both sides, right? So I sometimes will have an athlete maybe at a Pac-12 school and they'll say, oh, the ATC tells me it's their first ACL they've ever rehabbed, right? And I go like, maybe not the one to do, right? On the flip side, everyone has to have a first time, right? And so I think you're right. I think you can get into the weeds in the first 6 weeks, but probably not, because it's more sports medicine 101. It's inflammation control, it's range of motion, it's simple isometrics, quad activation. I think early on, maybe the biggest pitfalls or action item would be maybe hesitancy in terms of doing open chain exercises, or maybe hesitancy to really push on the patient on range of motion, or those types of things. I think later on, I think the biggest thing is to try to avoid those really ginormous leaps, right? So it's all a progression. You have to first do a 2-legged squat really well before you do a 1-legged squat. And you need glute control to do both of those things, right? So if you don't have great glute control, you're not ready to progress. And so once you have glute control and a good 1-legged squat, then you could start doing some running and some more dynamic activities. But we don't start off running at 100%, right? We start running at 50% effort, and then 60% effort, and 70% effort, 90% effort. And then once we progress on that, then we can start working on our, Z's and back, 45-degree back pedal, 45-degree back pedal, and figure of eights, and all those things. So I think the biggest thing would be progression. And the hard thing to learn is, when is it time to progress, right?
Mm-hmm.
And a lot of that comes down to quad and glute control and quad and hamstring balance, right? And so as long as you go slow, the progression should seem pretty easy. And so the later stages shouldn't be that scary, right? Because if they're starting to generate that great strength with all those things, then they're ready to, kind of acquire new skills. In some ways, I liken it to like the gymnasts who go out and they acquire a new skill on beam, and then another new skill, and then another new skill, once they have certain things mastered. But if you don't have the basics done, and you take someone out and have them run on a weak glute, they get patellar tendon pain. Maybe they get an effusion. Now the muscle shuts down more. Now we got a mess, because now we got to shut it all down again, control the inflammation, and go back to like stage one. So I think that progression is a big part of that, and getting a feel for that. I don't think the ATC should be scared of that stuff. But they also got to listen to the athlete, right? So if the athlete's complaining that my patellar tendon hurts, then be like, oh, maybe those split lunges were a little bit hard on the knee. And there are some big name physical therapists out there that are anti open chain exercises. Personally, because I did my training in Alabama with Dr. Andrews, Dr. Clancy, and a big name physical therapist named Kevin Wilk. Kevin's never been concerned with open chain early, as long as the patient's tolerating it pain-wise and you're not doing something crazy. So I don't mind open chain early, as long as, the patient's tolerating and it's not above their activity level. So I think the scary part is those progression things, but as long as you have your core basics and you keep building and building and building, I think it shouldn't be that crazy of an action item.
Dr. Shepard was talking about how this is kind of the stuff that he goes over with his patients, but I think that it's super helpful to sit down with an MD and actually get his perspective, and also hear from what doctors are telling our patients.
Absolutely, because it helps us kind of prep the patient going into like, hey, this is what they like to talk about, or here's what's probably going to happen on your visit. So then the athlete's already prepared, or the patient's already prepared, and maybe might be able to think of more in-depth questions than maybe if that was their first time being exposed to the information. So they can be a little more prepared going into that visit.
Exactly. And speaking of some of the info that he gives, so as promised, his website is michaelshepardmd.com, Michael, SHEPARDMD.com, and that's also in the show notes below. It has a bunch of patient info, education videos, post-op videos, preparing for surgery, interval programs. There's a whole
super
list.
in-depth. A lot of information.
So make sure you guys check that out. And also, if you guys are new to our podcast, we do every other episode as education or stories. This one was an education episode. Next week, we are going back to our stories. We do stories from real-life athletic trainers sharing their experiences as an athletic trainer in this profession. So if you would like to submit a story for our next episode, make sure you head over to our Instagram, where we put up story prompts for our upcoming episodes. Also, if you'd like to get connected with our community, go to facebook.com/group/ATcornerpodcast, where you can connect with other members of the show. We ask questions of the week. We put up discussions. You can go ahead and post in our Facebook group and just connect with others.
Absolutely.
Do you have anything else to add,
Nope,
Randy?
that was perfect. Thank you for helping us showcase athletic training behind the tape. Bye.